Good afternoon, good morning, or good evening, everybody, depending on where you're joining from. Welcome to this educational webinar, which is jointly organized by ASHNR and ESHNR. And today our webinar is going to be about neuro-ophthalmology. And this is part of our head and neck radiology clinical series. Greetings from Argentina. So welcome. So general housekeeping notes, please do use the Q&A panel to ask questions to the presenters following the presentation. The presentation today is going to be in two lectures. There'll be a first lecture, there'll be a small gap for questions, and then there'll be a second lecture. Please use the chat box to discuss and connect with your fellow attendees. But for a question to the presenters, please use the Q&A panel. CME credit is available for our session today, and you can go to the ASNR website to obtain that. You don't have to be an ASNR member to get the CME credit. You just need to have an ASNR login, which anybody can get. You don't have to be a member. So coming to today's lecture, Dr. Rucker is going to teach us a lot about neuro-ophthalmology, specifically to recognize classic disorders in neuro-ophthalmology and to help localize these disorders, which is going to help in patient treatment and outcome. We have no disclosures except for myself. I did give a lecture for Siemens. And very importantly, this year's ASHNR meeting is coming up soon. The deadline is actually coming up, I believe, in the next month or so. The meeting is in September. It's in San Diego, and it's a very beautiful place. And I hope everybody has marked their calendars and has started the process for registration for the meeting. Also, very exciting news is that we have a new joint program between ASHNR and BSHNI, the British Society of Head and Neck Imaging, where there'll be a visiting professor program. There'll be exchange of visiting professors on both sides. And we are kicking this off with Dr. Geeta Madani, who will be a visiting professor visiting us in the US very soon. Please, look at the website, the ASHNR.org website, and there's more details there. Now I will pass the baton on to Dr. Teresa Nunes from our ESHNR site, and she will guide you through the rest of the presentation.
Thank you, Dr. Moonis. Welcome, everyone. I'm very happy to be here in this webinar today, and I will start with some announcements. This year, the European Society of Head and Neck Radiology annual meeting will take place in Malmö, Sweden, from the 12th to the 14th of September. It would be great to see you there. Registrations are now open. And we also have a couple of upcoming webinars. It would be great to have you all on board. On the 15th of May, we will have an MDT case webinar with colleagues from Berlin. Next slide. Then on the 21st of May, we will have another ESHNR case webinar with two expert reviewers. You have more information in the society website. And finally, on the 28th of May, another webinar on imaging vestibular failure. I would also invite you, please, to follow both the American and the European Societies of Head and Neck Radiology on X. And last but not least, it is my great pleasure to introduce our speaker today, Dr. Janet Rucker. Dr. Janet Rucker is the Bernard A. and Charlotte Martin Professor of Neurology and Ophthalmology at the New York University Grossman School of Medicine, where she serves as the division chief and the fellowship director of neuro-ophthalmology. After medical school at St. Louis University, she completed neurology residency and neuro-ophthalmology fellowship at Emory University. Dr. Rucker currently serves as an editorial board member for the Journal of Neuro-Ophthalmology, has served many years on the North American Neuro-Ophthalmology Society board, and has over 1,000 peer-reviewed publications. Throughout her career, she has also maintained a deep passion for caring for patients with neuro-ophthalmological disorders, researching and teaching about neuro-ophthalmology. So I think we are really, really looking forward to the 2 lectures that Dr. Rucker is going to give us. I would remind all attendings to write your questions in the Q&A box. We will have a short break between the 2 talks to have some questions, and then we'll go through some more questions at the end. And without further ado, I will hand over to Dr. Rucker. It's a great pleasure. Please, the floor is yours.
Thank you so much. It is my absolute honor and pleasure to be here with you today. We have such a rich educational interaction with our neuroradiologists every day and the patients that we see and the conferences that we share. And it's such a rich learning opportunity in both directions. And I hope that I can impart some of the perspective from the neuro-ophthalmology side today and how we interface and think about the reads that we get, particularly on our orbital scans. It's a very broad topic, essentially our whole field, to talk about localization in neuro-ophthalmology. That's what we're all about. So what I've chosen to do today, given time constraints, obviously I can't be comprehensive, but I'll spend the first part of the session talking mostly about optic neuropathies, and then the second part of the session focusing in on some very highly localizing brainstem disorders. I came across this quote by William Shakespeare that says, "We know what we are, but we know not what we may be." And I think that nicely summarizes the relationship between the neuro-ophthalmologist and the neuroradiologist. Far more so than the general neurological exam, the neuro-ophthalmic exam is exquisitely localizing. And so we know right where we're at with the lesion most of the time, but we maybe have a clue what that lesion might be, but not until we get our radiology to confirm our suspicions or to encounter a surprise, as does happen occasionally, do we know what the answer is. So our collaboration with you is very important. I have no financial disclosures. So we'll begin with the optic nerve and its sheath. And I always remember my fellowship director saying to me that the optic nerve is a card-carrying member of the central nervous system, that it's a white matter tract, that it's surrounded by the pia, the arachnoid, the dura, and CSF, and so it is affected by most of the same processes that can affect the brain. Slide is not advancing here. So when we think about optic neuropathies clinically, we really divide them into anterior and posterior optic neuropathies, posterior being all of our retrobulbar optic neuropathies. The anterior optic neuropathies, by definition, have optic disc swelling, and the posterior optic neuropathies, by definition, have no disc swelling. We can look at the disc edema and get some sense of what the etiology may be. Of course, the age of the patient, the presence or absence of pain, the time course of the vision loss are all features that we hone in on. And then the appearance of the disc, for example, this disc here, it could be papilledema, but one thing I'm not going to talk about at all today is papilledema. We're going to really hone in on the very highly localizing optic nerve disorders. And if we looked at this disc that was swollen in an individual patient just in one eye, we would probably call that a papillitis. It might be ischemic or it might be inflammatory, and we wouldn't really be able to tell what the differential was here. Sometimes we see a disc that's swollen that has a lot of pallor to it. It's just a very pallid, pale optic disc swelling. And if we see that in an older patient, we're immediately going to be thinking about giant cell arteritis. And sometimes we see a disc that just has a little bit of swelling, but it's very nonspecific. There's no hemorrhages. And this one is a lot more difficult for us. The optic nerve has only so many ways to tell us that it's unhappy, and swelling is swelling from a lot of different etiologies. And even in patients with optic neuritis, which tends to be a retrobulbar condition, about a third of patients will have a little bland, mild disc edema. So optic neuritis is one thing that can hit every segment of the optic nerve. So for anterior optic neuropathies, just from examining the patient, there's no question about localization because that optic nerve is swollen. If the patient is presenting with acute vision loss, a lot of times that's going to be an ischemic optic neuropathy, which can be from giant cell arteritis, or there's also a non-arteritic version. The non-arteritic anterior ischemic optic neuropathy, we call NION, is the most common optic neuropathy we see over the age of 50. Under the age of 50, it's optic neuritis. So those patients who present to us with NION, we recognize that pattern of disc edema, the pattern of visual field loss, which is often the bottom half of the visual field, and we don't even typically scan those patients. Now, I put this scan here because this was an unusual patient I just saw last week who presented with what for all the world looked like a NION, an ischemic anterior optic neuropathy with a swollen optic nerve, but he was only 19 years old. So we did a big workup on him. We still think that's his actual diagnosis, but he did have just a touch of enhancement on this coronal T1 with contrast. This cut is just right behind the globe, and you can see just a little bit of optic nerve enhancement there, which on the axial is not as apparent, but if you look just right behind the globe, there's just a little touch of enhancement here. So occasionally, even with an ischemic optic neuropathy, it's been well published in a couple of series that you can see a little bit of optic disc enhancement, a little bit of optic nerve enhancement, or a little increased T2 signal. More often in younger patients, we have an optic neuritis with optic disc swelling if it's just a mild bland disc swelling, and we might call that a papillitis because the papilla, the optic nerve itself, is swollen. If patients present with an anterior optic neuropathy with disc edema, but they're presenting with slowly progressive vision loss, we're going to immediately be placed in the compressive category, mostly our primary optic nerve tumors. And occasionally, if there's a very significant disc edema, you'll pick that up radiographically too. This was something shown in our conference, Neuroradiology, Neuro-Ophthalmology conference last evening, and this was one of the most profound cases of disc edema visible on the MRI that any of us had seen. So I grabbed a snapshot to share with you. The posterior or retrobulbar optic neuropathies, we really think about that segment of the optic nerve in three sections: the intraorbital section, the intracanalicular section in the optic canal, and the intracranial section leading into the chiasm. And for us, different pathologies tend to affect the different segments of that optic nerve, but optic neuritis can span the gamut of all locations. So when we have an acute retrobulbar optic neuropathy, most often that tends to be optic neuritis, and typically the patient's going to have pain with eye movement. If we have a patient show up with a chronic progressive vision loss and it's a retrobulbar optic neuropathy, then we tend to think of the compressive and primary optic nerve tumors. So how do we know that it's an optic neuropathy? There's many things that can present with a normal fundus appearance, maybe a occult retinal pathology, very subtle macular pathology. So when we have a patient with vision loss, we're looking at their fundus appearance. Oftentimes with the acute retrobulbar optic neuropathies, we just see a completely normal optic disc. If it's chronic, We may see optic atrophy. There's an example comparing a nice normal disc on the left and an atrophic, very pale disc on the right. That will confirm for us it's an optic neuropathy. Loss of acuity and visual field are pretty nonspecific. Both optic nerve disorders and retinal disorders can cause this. We get these automated Humphrey visual fields, and we can get some idea from patterns. I mentioned earlier the inferior visual field loss of ischemic optic neuropathies, that's shown there. And then the other field is showing a nice central scotoma, very central vision loss, which is characteristic of optic neuritis. Loss of color vision is also nonspecific. We can see that both with optic nerve pathologies or with macular pathologies and retinal disorders. And we use these ESHNR color plates to assess color vision. But the real clincher for us that proves beyond a shadow of a doubt that it's a retrobulbar optic neuropathy is when we see the afferent pupillary defect or the Marcus gun pupil. And the reason we get that Marcus gun pupil is harking back to the pupillary reactivity pathway. So all of the information is going in through that optic nerve along the pink there, through the chiasm. And then when it gets back in the optic tract, it's jumping off into the midbrain. And then the efferent pathway begins at the Edinger-Westphal nucleus and out through the third nerve to the pupillary sphincter. So if we have an optic neuropathy, we have a reduced input of the afferent information in one eye. And when we shine the light in that affected eye, there's not as much light getting in. We shine the light in the normal eye, in this patient, the left eye coming, and we see normal pupillary reactivity. The relative afferent pupillary defect is when we do this swinging flashlight test. We swing to the normal eye, the pupil constricts. We swing to the affected eye, and the pupil appears to dilate because not as much light is getting into the affected eye. And those APDs can be very, very subtle for us. We'll look very hard for them because that's the thing that clinches for us that it's a retrobulbar optic neuropathy. Now, you're the radiologist. I am not, but I do spend a lot of time around orbital imaging, and I can definitely say firsthand that not all orbital MRIs are created equally. The scans are much higher resolution at certain places than others, and much better resolution on closed scanners than open, and stronger magnets. But the bare minimum that we're really seeking, what we pull up and look at the most, is those T2 fat saturated axial and coronal images and T1 fat saturated axial and coronal with contrast, both with thin cuts 2 to 3 millimeters. It can be very hard on the non-fat saturated images to tell, is there a little bit of increased signal or enhancement in the optic nerve, which will pop out at us very nicely with the fat saturation. So moving back to the segments and the most common pathologies that affect them, in the intraorbital segment, the obvious classic is optic neuritis, and then if it's chronic, the primary optic nerve tumors. Here's an example of a patient with idiopathic demyelinating optic neuritis. You can see that increased T2 signal in the left optic nerve, along with enhancement in the same segment. And we're really looking for that enhancement to tell us that it's an acute pathology. I put Lyme, lupus, and sarcoid in very small print down here because for the most part, these optic neuropathies are going to be our primary autoimmune optic neuritis, and only very rarely are they secondary to these other disorders. Syphilis should really be on there too. Primary optic nerve tumors, just the enlargement of the optic nerve with an optic glioma. This is a very large one on the left. They can enhance, they might not enhance. We can also see these types of tumors at the chiasmal level. And then on the right, we have a very classic optic nerve sheath meningioma. Beautiful presentation of seeing the normal optic nerve passing right through that meningioma that's enhancing, and in a very kind of asymmetric way, it looks like a mass structure, not like an infiltrative thing. So that would be the classic appearance of an optic nerve sheath meningioma. And for us, those typically are occurring in middle-aged women. So if we see a middle-aged woman come in with a retrobulbar optic neuropathy, an APD that clinches its localization to the optic nerve, we're getting that orbital MRI to look for that optic nerve sheath meningioma. Just a brief word on T2 hyperintensity with no enhancement. Time and again, we see a reads of optic neuritis on this. And when the clinician, be it the neuro-ophthalmologist, the ophthalmologist, the neurosurgeon, or the neurologist, when they see optic neuritis in a report, that's going to knee-jerk them to wanting to give that patient steroids. So I would just advise to hesitate to call it optic neuritis if there's no enhancement. Maybe just describe the finding, say it's a chronic optic nerve injury, or that it's not acute. It doesn't seem to be compatible with acute optic neuritis because there's no enhancement. Very often, it's just a patient who has very chronic optic nerve problem, and the optic nerve is very atrophic, and so it's very atrophic retrochiasmally too, and kind of looking bright on the scan, but it's just a chronic optic neuropathy. This is a nice example of a patient who has very advanced multiple sclerosis. He's been kind of slowly losing visual acuity over time. His optic nerves both are quite pale, much more markedly so on the left here. And I scanned him just to make sure actually that there wasn't a compressive lesion because he's slowly losing acuity. Nothing about his clinical picture suggested acute optic neuritis. So I wasn't expecting enhancement and there was no enhancement, but he definitely has some increased signal through the course of the nerve. And we'll see that also in chronic glaucomatous optic nerve injury too, patients with glaucoma who are missing a lot of their visual field. Occasionally, it is a true pathology, most particularly if there's also some optic nerve enlargement. Maybe it's an incidental optic glioma. Moving back to the intracanalicular space, the most common pathologies here, and these are less common, and I put the caution here because these are very easy to miss radiographically. You really, if someone just tells you vision loss as the indication for the scan, and we might not be paying a lot of attention at the intracanalicular optic nerve component, but trauma can affect these. Usually we're not going to see that anything on a scan with that, except for maybe some facial bone fractures or orbital fractures. But optic neuritis can definitely occur at the intracanalicular portion. The top image here, both arrows to a patient with bilateral simultaneous optic neuritis. And then the bottom one is a very clever kind of oblique angled MRI that I took from a colleague of mine who had published it that shows an intracanalicular optic nerve sheath meningioma. So for us, those would be patients who are just kind of slowly, progressively losing their vision in one eye. There's an APD, so we know it's the optic nerve, and there must be a compressive structural lesion. So we're going to come and say, let's look at that scan together and make sure we don't miss an intracanalicular nerve sheath meningioma. Another caution is that not all that enhances is optic neuritis. These are two patients of mine who had what radiographically would look like optic neuritis with enhancement of both optic nerves. But one of them was a young man who actually had a history of lung cancer, and his presentation was of carcinomatous meningitis. So he had a positive cytology on his spinal fluid. And the one on the right was a woman who'd had a clival-chordoma with some proton beam radiation. She showed up blind in one eye, normal vision in the other eye, but had this was about a year after her radiation, and had radiation optic neuropathy, was in a very precarious situation because we knew that she was going to go blind in her other eye, which was also enhancing on the scan. So not all that enhances is optic neuritis. And then lastly, in the optic nerve, moving back to the intracranial segment, optic neuritis can affect here as well. And also more commonly, we see compression in this location. So the left-sided image is an asymmetric pituitary adenoma. The patient presented with slowly progressive vision loss in the left eye. The right optic nerve was unaffected. This is a very anterior projecting adenoma, so it wasn't compressing the chiasm, but it certainly was very significantly compressing the left optic nerve. And then here's a patient who presented with a unilateral vision loss in one eye from a meningioma. And the bottom patient is just an intra-nerve lesion with enlargement and enhancement that turned out to be sarcoidosis. So optic neuritis these days has become very difficult for us clinically. We've got idiopathic demyelinating, we've got neuromyelitis optica, and we've got MOGAD, or oligo, I'm blanking on the term, myelin glycoprotein associated disease, MOG antibodies, and they can all clinically appear the same for us, but the MRI features may guide. And this is really helpful from radiology because we're putting that patient on steroids, but we're having to make treatment decisions about these patients before our labs are back. And so with idiopathic demyelinating optic neuritis, these patients do great regardless of what we do. They will recover even if we give them no steroids most of the time. We typically give them a few days of steroids and then rapidly taper. Our NMO patients have more severe vision loss and worse recovery, and they tend to, the literature is showing if we give them steroids immediately followed by plasma exchange, that they're going to have a better outcome. With MOGAD, we're going to give them steroids, but they have a high propensity to relapse, so we may taper their steroids slowly, like sarcoidosis. And I'll just point out this beautiful review paper here that came out in 2020 that really goes nicely over what's been published in these three disorders and what really differentiates them. Some take-home points: with idiopathic demyelinating MS, it tends to be unilateral and short segment. With NMO and MOG, they more frequently have bilateral involvement. They more frequently have a very longitudinally extensive optic neuritis, and they can more frequently have chiasmal involvement in neuromyelitis optica. With MOG, we often will see not only optic neuritis, optic nerve enhancement, but also a perineuritis. So here's an example of a longitudinally extensive optic neuritis with MOG, and here's a beautiful example of optic nerve sheath enhancement. The nerve itself was enhancing a bit in some segments, but the sheath was really lighting up. And on the coronals, this right one would be questionable, maybe normal, maybe not, but the left one shows beautiful optic nerve enhancement as well as very clearly defined sheath enhancement that you could follow back through the entire orbit. So MOG is tending to have swollen optic nerves and perineuritis, but it can also absolutely mimic idiopathic demyelinating with a short segment optic neuritis. And just to complete the discussion, be careful about calling optic neuritis too fast on these cases as well. This one with perineuritis and nerve enhancement turned out to be colon carcinoma by biopsy. So we have a classic differential for optic perineuritis that includes many different disorders. And young people with acute painful vision loss, we're thinking MOG, but there's quite a broad differential for optic perineuritis. So I think that I will stop there for the first segment and take any questions, and then we can move on in the second segment to discuss some brainstem motility.
Great, Dr. Rucker. That was an amazing review of this topic. I think we all, as radiologists, could learn a little bit more about how you localize the lesion. So, especially the part about the anterior versus posterior, I think that was very critical. That anything that's at the optic disc is considered anterior, which, as radiologists, honestly, is not very intuitive, because we think of anterior as like, the globe or whatever. We don't really think of the anterior disc as being anterior, like lesions being right at the disc. So I think that was a good learning point for me. We do have one question, which I believe you've already addressed, which was that what about enhancement? Oh, what about enhancement? No, I guess we haven't really talked about that. So Dr. Suhami said that, what about enhancement without T2 hyperintensity? So I have to say that I have not seen that too commonly. I don't know whether you have.
Not too often. I mean, sometimes the T2 signal change can be subtle, but I would say for us, enhancement is everything, because if we see enhancement of that optic nerve, we know beyond a shadow of a doubt that there is a problem in that optic nerve. Now, it doesn't tell us what it is. The clinical is so important for that. Just statistically speaking, more often than not, it's going to be optic neuritis if it's an acute vision loss situation. But I also think it's important. I think sometimes the neuroradiologists that I work with, will send a patient for a scan and we'll say optic neuropathy, and they won't find anything, and they'll be calling me saying, but we really don't see anything. It really is truly normal. We definitely see optic neuropathies that have normal scans. So a lot of times that we're getting a scan is to rule out something unexpected, to rule out optic nerve enhancement, and to rule out a compressive lesion. So most of our ischemic optic neuropathies, we may not see anything on the scan. Most of our hereditary optic neuropathies, like Leber's hereditary optic neuropathy, there are reports of abnormalities, like some chiasmal enhancement, but more often than not, the scan is normal. We're just getting it to rule out a compressive lesion. So you might not always see something, even if there's a definitive optic neuropathy on exam.
Great point. There's another question, somewhat similar, from Khadija Ahmed. If there's adjacent intracorneal enhancement or stranding, would you think there's optic neuritis plus perineuritis? Sometimes it is difficult to tell with an enlarged or abnormal nerve. I think their question is that, whether how do you tell perineuritis from optic neuritis? And I think that's a good point. Is optic neuritis is going to be in the nerve itself, and perineuritis would be more in the walls.
Sometimes we just see perineuritis with no optic nerve enhancement. When we see the combination of both, that's a very MOG, myelin oligodendrocyte glycoprotein disorder. That is just seeing the combination is very suggestive, but it's not specific. I mean, sarcoid could do that, syphilis could do that. We still have a differential there and things to work up. And I think in the heart of the orbit, it's much easier to see the enhancement of the nerve sheath. When you get very posterior in the orbital apex region, things get really tight back there, and it can be really hard to tell for certain, is there nerve sheath enhancement or not? But it's really, if you see it prominently in the orbit, point it out with your optic nerve enhancement. It is very different. Idiopathic demyelinating optic neuritis, the one associated with MS, is not typically going to have that nerve sheath enhancement along with it. That really points us towards MOG.
Right. And on the same note, I mean, if we have a nerve that is T2 hyperintense and maybe somewhat atrophic without enhancement, I think in our report, we can say that this is optic neuropathy. We will not say optic neuritis because we're not seeing active enhancement. But I I think it is probably okay for us to say that we are seeing evidence for optic neuropathy. Is that acceptable?
Absolutely. Okay. And I would just say that I've definitely seen optic neuritis in reports, external reports from out in the community, or depending on the radiologist's familiarity with orbital imaging. I just would caution against the use of the actual term optic neuritis, or if it's called optic neuritis, specifically point out in the report that there's no enhancement, so it's not likely an acute thing.
Great. And then we have a third question from Dr. Sethi. Hi, Bindu. How are you? Her question is, what would be the clinical symptoms of optic perineuritis alone? Will it still be APD?
That's a great question. So perineuritis has kind of shifted in its meaning for us. Perineuritis used to be something that we would diagnose if we had a patient who looked like papilledema, both swollen optic nerves, but their intracranial pressure was normal. We used to say that was perineuritis. That's kind of fallen by the wayside, and now it is a very MRI-based diagnosis with that much more sort of inflammatory flavor differential, IgG4, sarcoid would be the kinds of things. It would be along the lines of idiopathic orbital inflammation if we saw an isolated perineuritis without any optic nerve involvement. And clinically for us, those patients may or may not have an optic neuropathy clinically. For example, giant cell arteritis can be a cause of perineuritis. They're typically presenting with a big swollen optic nerve and a really bad vision loss. We get the scan, we see perineuritis. That has been well reported with giant cell arteritis. The patients who tend to present with things like IgG4, sarcoid, they're really presenting oftentimes, well, not sarcoid so much, but idiopathic orbital inflammation with eye pain. And so we're scanning them just because they have eye pain. Maybe their exam's actually totally normal and there's no APD, and we find perineuritis or maybe some orbital fat stranding. That's our differential going to go down the line of ANCAs and IgG4 and sarcoidosis, and kind of a different mindset than if they have vision loss, if they're older giant cell, if they're younger MOG. So there's a lot of variability in the exam presentation with perineuritis.
Great. Awesome.
We have another comment from an anonymous entity, stressing also the importance of follow-up in odd cases. I totally agree with that. And the comment that he has seen a couple of cases where GBM diagnosis was missed for quite some time and follow-up would have helped. And the question whether a 19-year-old man could have an GBM of an optic nerve.
It's highly unlikely for him, and no question he will be followed. I saw him last Wednesday, admitted him to the hospital. He got discharged Saturday, and I saw him again yesterday. So he will be followed like a hawk, I guarantee it. But that's an excellent point, because sometimes things don't make sense and fit into a known box for us, for you. And so we're always following those cases very closely, looping in our colleagues to discuss them, seeing what we could be missing. And any unexplained optic nerve enhancement absolutely needs to be followed for resolution or progression. It's a very important point. Thank you.
And maybe for both clinicians and for radiologists to just stress when we think that something is odd in both the clinical picture and the imaging picture that we are dealing with. And that communication, I think that sometimes really gets us to the final diagnosis, knowing that something is odd, that maybe we must broaden our differential diagnosis or do some extra investigations, either follow-up exams or other type of investigations. I think this goes both ways, both for the clinicians and for us as radiologists.
Absolutely. We interface with our neuroradiologists every day, and there's so many cases that we've solved just by coming together and discussing them. So very great point.
That's right. Yeah, we're really privileged to have you as one of our clinicians, Dr. Rucker. So yeah, it goes both ways. So I think this is a good time for us to get on to the second part of the talk. Dr. Rucker, you can take it away now.
Great. So I can never give a talk without doing some eye movements because that's really where my research passion lies, and some difficult cases to crack, especially when the radiographic findings are subtle. But I just want to kind of give a high-level overview of some of the exquisitely localizing things that we see, because I feel like you radiologists never get to see the eye movements, and they're kind of fun to look at. So we'll get started. So first, I'm going to talk a little bit about the classes of eye movements and their anatomic substrates, and then we'll review a few midbrain disorders and a few pontine disorders. So I think it's really an interesting question to ask. Why do we move our eyes in the first place? It's because largely we have a fovea. And when we look at things, we place our fovea right on it. So the thing we're looking at, the man in the center of this picture, he's nice and clear and sharp and crisp, but something gets even a couple of degrees off the fovea and our visual acuity plummets by 50%. So we are constantly moving our eyes in order to have a sharp, crisp view of our world. So our eye movements exist to place and maintain the fovea on what we want to look at. So we have movements that hold it there, and we have movements that get it there by moving it. So fixation is very active. We have brainstem mechanisms that are holding our eye in central gaze, holding our eye in eccentric gaze. We can have lesions of those where we get nystagmus because the eye can't hold steady. We have vestibulo-ocular reflexes or doll's eye maneuvers, so that when we're talking, walking, moving around, we can maintain our fovea on what we're looking at. We have smooth pursuit to follow slowly moving targets. We have vergence to shift our eyes between 3D, near and far. We have saccades, which are my favorite, get up to 600 degrees per second, exquisitely fast eye movements that have their own brainstem machinery to move that fovea from target to target. And each of these eye movements is achieved by the cranial nerves, the neuromuscular junction, the eye muscles, but they all have different supranuclear pathways feeding in to the cranial nerve nuclei to send out the signals for the different types of eye movements. So the fact that they all have different supranuclear substrates means that they can be affected by lesions in isolation. So you could have a lesion that affects saccades only, but spares vestibular, for example. And that's why eye movements in the brainstem can be so exquisitely localizing. So here's just an example of normal, healthy, smooth pursuit. Moves 20 to 50 degrees per second, should be very smooth. Vestibulo-ocular reflexes, we've got just normal doll's eye maneuver. We move the head up and down. She can maintain fixation on what she's looking at despite the head movement. And then saccades are very rapid jumps between targets. And we look at kind of how do they start? What's the speed of the movement? Are they landing accurately? And each deficit of saccades has a different localization. So a lot of brain pathways contribute to these eye movements. There's frontal eye fields in the frontal cortex, parietal eye fields, etc. But they all feed down into that kind of final common pathway from cranial nerve nucleus to nerve to neuromuscular junction to muscle. So for orientation here, we have a mid-sagittal section of the brainstem, thalamus up top, medulla down below, cerebellum behind. And I've highlighted with some symbols the structures that we're going to kind of highlight right now. So we've got our sixth nerve nucleus down here in the caudal pons, in the rostral portion, six nerve rootlets coming out. We have our third nerve nucleus up here in the midbrain, third nerve rootlets coming out ventrally. Just above that sixth nerve nucleus we have this yellow triangle, which we'll come back to. And just above the third nerve nucleus, we have this triangle. We have our posterior commissure, and then, of course, our medial longitudinal fasciculus, or MLF, connecting the sixth and the third nuclei. So these triangular areas, they serve saccades only. So for horizontal saccades, the commands are generated in the paramedian pontine reticular formation in the pons, just above the sixth nerve nucleus. For vertical saccades, they're the rostral interstitial medial longitudinal fasciculus, the RIMLF, so just above the third nerve nucleus. So let's move into midbrain disorders of saccades. We can have a lesion of the RIMLF. Our classic lesion, actually, if it's acute, stroke. If it's chronic and progressive, we've got our progressive supranuclear palsy patients, PSP. So here's an example of a patient who had acute onset vertical gaze paresis. They couldn't look up or down because of bilateral involvement of the RIMLF. Acutely, it can affect all the eye movements up and down, but eventually, as it heals, it's mainly going to just cause saccadic slowing, which is what you see in the video. These eyes are just moving very slowly and incompletely up and down. So this patient had bilateral lesions affecting the RIMLF. This is a coronal view, but these lesions always almost look like they're in the thalamus because it's so high in the midbrain, right at the midbrain thalamic junction. And the other kicker that tells us that this is an RIMLF lesion instead of bilateral third nerve palsies or something like that is that these eye movement problems are overcome by vestibular reflexes because the RIMLF is for saccades. So vestibular responses are spared. So here we have an example. A patient can look up fine. The patient can't look down at all. But when we do the vestibular doll's eye maneuver, we can move that eye down no problem. So we can see that this is a problem of saccading down, but not all downward eye movements. And we're going to hone in and say, let's look at the RIMLF for that patient. The RIMLF is interesting from a vascular supply standpoint. Here's another example of a patient who had acute onset vertical gaze paresis. And so the blood supply is the thalamic subthalamic paramedian artery to the RIMLF. And most typically, patients have one on each side, just like most of the vessels, but there can be a single artery and it's to the thalamus, but the RIMLF is right below it. And so if you knock out that single perforator, that single vessel, you can get a bilateral vertical gaze paresis from bilateral RIMLF lesions, and that's going to be the artery of Percheron when there's a single thalamic subthalamic paramedian artery, and that's present in about 20% of patients. So we definitely see that in acute stroke. Another vertical gaze paresis that's a little bit different in the midbrain is our dorsal midbrain syndrome or perinode syndrome, which is supranuclear. It's not affecting the third nucleus. It's the pathways feeding into 3 to tell it what to do. And this is just an upgaze paresis. But there's other findings with it as well that clinch it for us as a dorsal midbrain syndrome. So you can see that this patient can't look up. Here's one example of a lesion that caused this problem. That's a pineal tumor. And the other findings, so it's not just an upgaze paresis. If it was, we might think RIMLF, but they also have this funny pattern of nystagmus called convergence retraction nystagmus. So if you look at the bridge of this patient's nose and try to kind of look at both eyes at the same time, you see the eyes kind of moving in towards the nose at the same time, kind of converging. And then very strikingly, when you look at her from the side, the retraction component of the nystagmus. You actually see the eye being retracted into the globe with the nystagmus. So those two features together tell us we're dorsal midbrain syndrome, plus they get a lot of eyelid retraction. We tend to think of that as causing orbital pathology, but eyelid retraction can also be a midbrain sign. And they get some pupillary involvement. So the classic pathologies, these lesions are affecting the posterior commissure, kind of right at the superior colliculus. And so the classic pathologies here would be that big pineal tumor that I just showed you, or even patients with hydrocephalus and raised intracranial pressure. And once in a blue moon, we'll see a patient with acute onset dorsal midbrain syndrome who has it from stroke. Of course, the intranuclear ophthalmoplegia is our kind of first brainstem eye movement problem we learn about in medical school. And this is our impaired adduction of one eye. So you can see that this patient's right eye doesn't move in towards her nose. And when she looks to the left, she has this abducting nystagmus of that eye. And our classic features of the INO. This lesion is so exquisitely localizing to the medial longitudinal fasciculus. Even if the MRI is normal, we know that we have an MLF lesion in that patient. So why do we have the MLF? We have it because if we're going to look to the right, for example, in order to do that, we need our right lateral rectus, we need our left medial rectus to make the eyes move together to the right. So that right lateral rectus, of course, is innervated by the sixth nerve on the same side, and the medial rectus is innervated by the third nerve on the other side. So we need that MLF to connect the two. And this decussation in the pons is very, very short. And then the ascending portion is much longer. So the lesion is always on the side of the impaired adduction. So if we have a right INO with impaired adduction on the right, we're going to be looking on the right side for that lesion. So of course, MS is a very characteristic cause of intranuclear ophthalmoplegia. It's the initial demyelinating event in 15%, and depending on the study, but anywhere between 17 and 41% of patients with MS have one at some point in their disease. They can be unilateral or bilateral, they can be acute or chronic. We also see acute onset INOs, either with other abnormalities on exam or in isolation with stroke. And so it's so exquisitely localizing. I'm going to skip those two for the sake of time. And just point out, this is an old study, but there have been newer studies that have shown the same, that T2 is much better for detecting lesions in the MLF than FLAIR is. FLAIR often will not show the lesion. In this study, it was FLAIR about 50% of the time and T2 about 90% of the time. And to wrap up, this is an amazing, amazing video. So we covered the RIMLF. If you have an RIMLF lesion, that controls your vertical saccades and vertical eye movements, so you're up in the midbrain. If you have a horizontal gaze paresis, that's mainly affecting saccades, you're going to be down in the pons, in the PPRF, in the paramedian pontine reticular formation. Now, of course, on MRI, human lesions are messy. They don't just hit the PPRF, but our clinical exam gives us a general idea of where in the brainstem that we're going to be looking. So this was a demyelinating lesion in a patient who had a horizontal gaze paresis from PPRF involvement. This patient that I'm going to show you was a patient we saw fairly recently here who had a cavernoma that bled, and she had an isolated problem with her eye movements that is so characteristic of PPRF. What you're going to see here is when she pursues something to the right, she does okay, gets her eyes over. But when we say, now jump your eyes to the right, they move like molasses.
So keeping your head still, straight at the camera there. And keeping your head still, follow my pen slowly here.
So she goes left, okay. She's doing pursuit, following the pen with my colleague, Dr. Grossman. And the eyes move over, don't seem to be any problem.
Great. And when I say pen, look at the pen. When I say finger, look at my finger. Finger?
And you saw normal saccades in a video earlier. These are molasses. Slow. She can barely get her eyes, but it's only with saccades. And so we know that's going to be PPRF. I'm going to skip that because we are up on the hour and I want to allow some time for questions. I'll show you this last case, which is kind of a combination of a horizontal gaze paresis. So this patient can't look to the right, but he also has a right INO. When he tries to look to the left, he can't adduct, he can't bring that eye towards the nose, and he's got the nystagmus. This combination of MLF, of INO, together with inability to look in the other direction is our 1.5 syndrome. And it's so exquisitely localizing to that caudal dorsal pons. And so you see he had a acute hemorrhage here that was ISO intense with the brain acutely, but it was showing up on the SWI imaging as a hemorrhage. So I will end there and be happy to take any questions in the last couple of minutes. Thank you so much.
Thank you, Dr. Rucker. That was amazing. Does anybody have any questions? I don't believe so.
See any
Teresa,
questions?
you have a question? Yeah.
No, I don't see any questions on the Q&A. I see some congratulations on the great lecture from Rodolfo Capozzi. And I think that we all share that opinion. And again, stressing some of the points of really needing to have a good imaging protocol to show all these lesions in sometimes very tiny structures.
And also shows you that you need a great neuro-ophthalmologist to help us with, localizing things at the right spot. And that's why I feel so blessed and lucky that I work with Dr. Rucker as one of my colleagues. And I think it's definitely just looking at all those localizing lesions. I was like, oh my God, I do not remember any of that anatomy. It was going way back to med school.
It's so much fun, but it truly is a two-way street, and we would be completely ineffective without great neuroradiology. So we really are grateful to the opportunity to, discuss cases and help our patients. And we couldn't do it without everyone on this call. So thank you all.
I think we have another question on the Q&A from B. Kovacevic. Do you inspect the nystagmus eye movement with Frenzel glasses?
Yeah, that's actually a very complicated question. So there's many different kinds of nystagmus, and a lot of them, like in MS patients, in cerebellar patients, we can just see the nystagmus with our naked eye. But just like a weakness in half of the body could be super, super subtle or a complete plegia, same thing with nystagmus. It can be really obvious or it can be very subtle. Where Frenzel goggles are the most helpful, and I saw there's a vestibular radiology talk coming up, so you'll probably attend that one. Maybe it'll be touched upon the clinical part of vestibular. What's true about vestibular nystagmus is that if you have a dizzy patient in the emergency room and you just say, follow my finger, and you don't see any nystagmus, you're not done. We pull out the Frenzel goggles. What the Frenzel goggles do is they're basically really, really strong reading glasses. so strong that you just really can't see anything through them. And so they give us a magnified view, but they also eliminate the patient's ability to fixate on anything. And that's going to pull out some of our vestibular forms of nystagmus that help us localize dizziness.
Great. So if there are no further questions, we will call an end to this webinar. Again, thank you, Dr. Rucker, for an amazing educational effort. I mean, we all learned a lot from this. And I also wanted to let everybody know that recording will be available on the ASHNR website, the Education Connection recording. So you can just, access this recording later. So thank you again, everybody. Have a good one.
Thanks,
Thank you, Dr.
everyone.
Thank you
Nunes.
very much for all of those attending and for Dr. Rucker for those magnificent talks.
Bye-bye.
Bye-bye.
Bye-bye.